So here we are in the deep dark depths of winter, trying to work out how to make our lives more comfortable. Why not get sat by the fire and enjoy some Fireside CPD with the Fireside sessions. Alan Taylor here with a chat, a friendly chat about cranial nerves and a bit of a clinical reasoning guide. So rather than a guide to how to test them, it's a little bit of an introduction or a get to know you thing for the cranial nerves, because we kind of, although many of us have seen these diagrams in textbooks and maybe on posters on walls, we're not actually that familiar with the cranial nerves, and that's for a variety of reasons. When I posed the question on Twitter some time ago, we got a really good response, over 600 votes, and 53% of people all around the world made the suggestion that they weren't really taught the cranial nerves at university, which is kind of interesting. And then in a follow-up question, I asked those that had been taught it whether they were sort of comfortable applying it and interpreting the findings in clinical practice. And again, well over half suggested that even if they had been taught the cranial nerves, they weren't really that comfortable with the application. And there's a range of reasons that might link to that. And we'll look into that as we go. I don't think it's anyone's fault. I don't think we're trying to apportion blame here. I think it's just a product of the system and the way education's just been built historically. So let's try and put things right as best we're able. So a quick question for you all. So if there was somebody with some peripheral symptoms in the arm or peripheral symptoms in the lower limb, would you test the neurological system as part of your examination? And I think most of you will probably have a hand up at this point, which is kind of interesting, because we kind of know from chatting to people on courses over a long period of time now that people will test upper limb neuro, they will test lower limb neuro. But when it comes to perhaps the riskiest sort of anatomical region of the body, we don't seem to have been equipped educationally or philosophically even to consider the testing of the cranial nerves. And it's a long-standing puzzle to us why that is, but let's try and put things right as best we're able. So we are in, technically, as I've just said, this risky area of the body where if we make the wrong decisions about how to proceed, then we may find ourselves seeing adverse events. So the question for everybody has got to be, I guess, okay, cranial nerves, I've heard about the cranial nerves. When really in the clinic should I consider testing them? And hopefully the purpose of this chat is to try and get us familiar with the cranial nerves, put them in context with regard to clinical reasoning, and really just get to know them and their function a little bit before we rush ahead and try to test them. Because if you haven't got any idea about what they do and why they're there and all the rest of it, which we seem to have lower limb and upper limb, then it makes it hard to sort of put into context. So let's try our best to sort of approach that steadily. There's a very, very colourful representation of the nerves. You'll see the numbers are there on the left. The cranial nerves are quite nice. They've got individual names. And you'll see there the names in that second column. And what's interesting in the third column is just to note that some of them are sensory, some of them are motor, and some of them are mixed. So if you run down that type column, you'll just get a sense of that. You might be puzzling over the colours. I'll try and explain why the colours are there a little bit later on, because what tends to happen is you tend to dart around when you're testing these, and there is a way to do this in a slightly smarter way. So I'll put the functions there in the function column, and then the examination is there just for interest, but we're not going to go too much into examination today. It's an opportunity to familiarise yourself with the nerves before we go into the descriptions of how to test them. Cranial nerve 1, the olfactory nerve. We know this is a sensory nerve. It's all about the sense of smell, and the loss of sense of smell is known as anosmia or anosmia, depending on how you decide to pronounce that. And we know that this is often happens as a consequence of head injury, and that can be with or without skull fracture. So we do know that people who've suffered head injuries often report an ongoing loss of sense of smell. It can follow blunt traumas. An example would be a road traffic collision or head injury in sport. So if you've seen any of those types of patients, then it's a consideration for you. And we do know that lots of professional boxers or fighters often suffer a loss of sense of smell as a result of repeated trauma over time. And we also know that temporary losses can occur in response to inflammatory processes or in relation to infection or allergy. What's interesting at the moment, I guess, with COVID-19 is one of the key signs that you pick up with that is a loss of taste and smell, and certainly there's lots to be considered with regard to that. So there might be another potential reason for adding in this to your skill set at the end of the day. Okay. Number 2, optic nerve, again a sensory nerve. So these are paired nerves that give this visual information from the retina to the brain. And again, in terms of mechanisms of how this nerve might fail, there's a range of different things, and one of them is neuritis or inflammation, which is thought to be occasionally linked to the early signs of the onset of multiple sclerosis. So if people are sort of describing visual symptoms, there may be a consideration of whether this is an early sign of a neurological manifestation. Glaucoma is quite a common one, affecting the optic nerve due to high intraocular pressures, which affect the nerve, causing the cells to die, and we get atrophy of the nerve in those situations. So again, if you suspect somebody of having glaucoma, that might be again a consideration for you. Really interesting one is nutritional optic neuropathy. Causes progressive visual impairment, and it's apparently becoming increasingly common due to the widespread use of bariatric surgery and these strict vegetarian and vegan diets that lots of folks are using at the moment. And then another mechanism would be an ischemic optic neuropathy, so reduced blood flow to the optic nerve, and this could be linked to just atherosclerosis, or it's commonly linked to an inflammation or arteritis. So giant cell arteritis is a condition which will present as a headache in a particular profile of patient, and certainly is worthy of consideration if you've got a headache presentation, that you would sort of put this all together and consider testing the optic nerve as part of your workup for diagnosis. Cranial nerve 3, the oculomotor nerve. As in the description, this is a motor nerve. It's all about eye movements, and it's most of the eye movements and also the muscles that raise the eyelid. What we see in dysfunction of this particular nerve are disorders that impair the movement or the pupillary function, or sometimes both. So what we can tend to be looking for on observation are signs of diplopia, or a drooping of the upper eyelid, otherwise known as ptosis. And this can occur in a range of different conditions. We're looking at the eyes to see if the pupil's dilated, and then we might test for light reflexes, and that's part of the workup on the testing. One of the things that might happen is that the affected eye might deviate slightly out and down if the person is asked to make a gaze straight ahead. And adduction may be slow and not proceed past the midline, so that's a sort of manifestation. So it's a reason to look at the eyes as part of examination, and we may see upward and downward gazes affected as well as that adduction. So now we're on cranial nerve 4, the trochlear nerve. This is a motor nerve, and this impairs the superior oblique muscle, causing paresis of the vertical gaze, again mainly in adduction. Interesting that it may affect one or both eyes, and classically patients report seeing double images. The eyes do not adduct when you look at them moving. Impairment might affect everyday function, and they may be complaining of dizziness or balance issues, walking in crowds or supermarkets, or going up and down stairs in crowds, of which you don't get so many of these days. Some of the possible causes, this may again be linked to head injury, again causing unilateral or bilateral palsies. It's thought to be linked to small vessel disease. An example is folks who suffer diabetes. So if you have somebody with a comorbidity of diabetes and they are also complaining of visual or balance issues, then again a consideration to possibly test cranial nerves. And there's a range of other things that are quite rare, from aneurysms through to tumours through to the, again, onset of MS. Number 5, trigeminal nerve. This one's a mixed nerve, motor and sensory, and as you see on the right there, one of the manifestations of pain, and it's usually facial pain, and we see patients with neck pain and facial pain on a regular basis. So what are we going to look at here? If you've got patients with this descriptor and they've got this sensitivity to touch or allodynia, that's a reason why to consider testing the cranial nerves and look at trigeminal nerve in particular. It's thought to be caused by compression of the nerve, and that can be due to pressure from any structures. One example is an aberrant loop of intracranial artery, as described there. So again, unusual but potential, and this is around the sort of brain stem area. Less common causes include compression by tumours, AV malformations, aneurysm, and again MS crops up. So we're looking at a range of different potential pathologies. So they could be links to vascular pathologies, could be linked to neurological pathologies. Okay, and again, that's commonly in these sort of younger patients that might be in the early stages of an MS development. ABDUCENS nerve, again motor, its key function is the eye movements, and the mechanisms that we tend to see is again this time an impairment of abduction, and again there's a link to head pain. So again, if we've got patients with headaches, unusual headaches, it's a classical time when we should be considering taking a look at these nerves. Because of the impairment of abduction, the eyes may be slightly adducted when the patient looks straight ahead. So what we tend to see is impaired abduction and a horizontal diplopia with these patients, and that's something that you look at when you do your testing. Again, why might this happen? To be secondary to sort of nerve infarctions and a range of other things like encephalopathy, trauma, infection, increased intracranial pressure for a variety of different reasons, and again vascular reasons such as vasculitis, or it just may be an idiopathic issue. And if there's a suspicion of vasculitis, there may be a need for lumbar puncture and sort of further testing such as MRI scans or combinations of all. So once again, this presentation of headache is classically a time when you'll be considering testing these nerves. Mixed nerve, cranial nerve 7, the facial nerve. This is one of the nerves that sort of serves the sense of taste. This is the anterior 2/3 of the tongue, and also information from the ear, but probably classically it controls muscles of facial expression, and that's why when we test we ask the patients to sort of make different faces so that we can see if they're able to use all of their muscles. So it's the classical Bell's palsy presentation, a sudden onset unilateral peripheral facial nerve palsy that we're all probably quite familiar with, but it is commonly linked to impairment of this particular nerve. And this is one thing that we're probably more familiar with than some of the others. And again, it's thought to be a swelling of the nerve or an effect from an immune or viral disorder, causes compression, and often these things are treated early with oral steroids as part of the management of the cases. And classical evidence at the moment is suggesting that common viral causes of herpes simplex and herpes zoster might be linked to these things, and there's a range of other things that might come up as well. So it looks like it's another one of those cases where they're not entirely sure of why this might occur. Okay, moving on, cranial nerve number 8, vestibulocochlear nerve, hearing and balance. All right, so again, if someone's reporting that their balance might be impaired as part of their presentation, or you've become aware or they've become aware that their hearing might be affected, then it's an indication to test the cranial nerves and make sure vestibulocochlear gets included in that. And classically they'll be describing sort of hearing loss, maybe vertigo or whatever descriptions they use. They might have a sort of seasickness or a false sense of motion, and classically they'll have a loss of equilibrium or feel dizzy, especially in dark places where they lose the input from the eyes. You may be able to pick up some nystagmus when you come to the testing later on. Okay, so there's a range of different things, and there may also be a link to tinnitus. So there is a thing known as gaze-evoked tinnitus, which might be linked to the impairment of this nerve. Okay, so a range of different things that we ought to be aware of, I guess. Glossopharyngeal nerve, mixed nerve, this time the posterior 1/3 of the tongue, and it serves the sort of function of the tonsils, the pharynx, and controls some of the muscles used in swallowing. So if you get somebody who explains to you as part of their presentation of maybe neck pain, headache, etc., that they're having difficulty with swallowing, it's an indication to test that. But again, as you can see, right hand side, upper part of the diagram, it's linked to unilateral pain, and it's often excruciating pain, and it can occur spontaneously. But it might be linked to sort of mechanical actions like chewing or swallowing or coughing, talking, yawning or sneezing, etc. So it seems to be an unusual presentation once again, so consideration of testing cranial nerves once more. They might describe pain beginning in the back of the throat or the tonsils region and radiating towards the ears. That's a classical description. And this difficulty swallowing would be almost a no-brainer to put cranial nerves into your thinking for the examination for these patients. All right, and you may be able to pick up some ideas around sensation if you decide to go ahead and test that as well. As part of this, this is the classical thing where the doctor will ask you to say "ah" and you look inside the mouth. As part of this, there may also be an absent gag reflex, so that sometimes occurs. But we know gag reflex is missing in lots of normal individuals as well. Okay, and there's a range of reasons why people might get that. And again, aberrant sort of branches of arteries are just one example, and that seems to be a common thing that comes up. But again, any space-occupying lesions such as a tumour or peritonsillar abscess, and rarely a carotid aneurysm, or once again, demyelinating disorders like MS might be the root cause for this. So again, you can't always tell exactly what the patient might have, but certainly you can decide that it might be a reason for them to go on to further examination. Up to number 10, the vagus nerve, mixed nerve, sensory motor, and it's linked to autonomic function, the viscera, glands, digestion and heart rate. And again, characterized by loss of reflex contraction of the palate. Once again, it's the part of the R examination. The patients might report hoarseness of the voice or a change in the quality of their voice, which they might put down to some other reason. Again, a reason to test the cranial nerves if someone reports that. And it can be associated with an abnormal cough, but at this time of the year, lots of people appear to have abnormal cough, so we'd have to make sense of that as best we're able. And it tends to produce pharyngeal paralysis. So again, this is classically tested by that test I've just described. And you'll be able to see it clearly when we come to looking at the testing. Number 11, which is the spinal accessory nerve, sometimes just called the accessory nerve. This is just motor. We might be more familiar with this because we do muscle testing, and this is classically testing upper fibers of trapezius and sternocleidomastoid, which would be part of our general workup anyway, but we may not sort of link it into the dysfunction of the nerve always. And you may be able to observe changes in muscle mass in the sort of observation of the neck, leading to an asymmetrical neckline. And you may see some of those mechanical sort of observations of drooping of the shoulder or a winged scapula, which could link in to paralysis of this nerve or dysfunction of this nerve. So when you're looking at your observation and you're seeing that, again, that would be a reason to consider putting cranial nerves into your examination procedures. It's rare, and it seems that surgical procedures are one of the most common causes of injury to the spinal accessory nerve, so that's probably one of the more rare ones that you may see. And now we're at number 12, the hypoglossal nerve. So this is the time when we get patients to stick their tongue out, so we can have a look at it. It's a motor nerve, and the key things we'll see is a sort of flaccid paralysis or a weakness of the muscles on the same side as the lesion, and we can find a range of ways to look for that and test for it. What's interesting is that when the people with problems with this nerve attempt to protrude their tongue, it deviates towards the weak side because the strong muscles on the other side tend to push it across. Okay, so that's slightly different to maybe how you might interpret the eye weakness earlier on. Okay, and we can see fasciculations on the tongue too. Right, what I've done is I've reordered the cranial nerves just to try and help you when it comes to examination. It's very, very easy to put 1 and 8 together. That's why I've got yellow colour. You can very quickly do some tests of smell and some tests of hearing. So I've got those ones out of the way. Turquoise colour, you're able to loop 2, 3, 4 and 6 together and do a range of different eye movements, so that makes it a lot easier. Then you can come to the sort of face and head and do a range of things around the mouth, etc., etc., with the ones in the sort of red colour. And then finally you can do your muscle testing at the end for the accessory nerve to finish off. So by altering the order slightly, it actually makes the testing a little bit more logical. Alright, so stop the video for a second and just have a quick thing. A pause for a moment and think about what presentations you might consider that you might see in front of you that might make you consider testing the cranial nerves. So make a quick list and let's see how that list matches up to this. So let's look at some of the presentations that you might see in front of you. So classically, of course, loss of smell, any alterations in vision, so anything that the patients might describe. Drooping eyelid would be a giveaway to put cranial nerves into the testing, or alterations in the size of the pupil. Facial pain or allodynia would be another classic description that would make you consider it. If you saw facial paresis, so the classic Bell's palsy, once again, let's do a full workup of cranial nerves to see how they're functioning. If this patients are reporting hearing loss, which they may do, vertigo, motion sickness, unusual descriptions of balance issues, tinnitus would be something else, and is that linked to eye movement? That would be another thing to consider. Again, difficulty swallowing, alterations in the voice, those sorts of things. They're all sort of having difficulty with food, perhaps. So that would be a combination of altered gag reflex and difficulty swallowing. I've mentioned changes in the voice, and then any odd autonomic dysfunctions like strange alterations of heart rate that might implicate vagus nerve, and then any sort of weakness or apparent atrophy of the muscles around the neck, sternocleidomastoid and upper fibers of trapezius. All right, so hopefully you will have got a few of those on that list. And classically, again, one more thing to add is the sort of tongue weakness or tongue function. So the patient might describe it as, I'm having difficulty eating again. And when you investigate that, it turns out that it might be worth testing for tongue function here and muscle weakness. If you now stop your clock and make a little list and try and think of a few potential pathologies that might link in with those presentations that you've just seen or we've just chatted through, and think about what conditions or pathologies that might be possible comorbidities, or that you might be suspecting as part of this sort of idea around whether you test the cranial nerves or not. So let's put that list together for you. Again, it's not exhaustive. This is just some of the things that you could consider. So certainly any patients with head injury, again, classically they could fall into the category of patients who need to have testing of cranial nerves. Road traffic collisions would be another one. Inflammatory conditions. I mean, is the inflammation affecting the neural tissue? And is it the reason why they've got some symptoms that they're describing? Could there be glaucoma affecting the eye? Patients who've got atherosclerosis, have they got specific lesions such as maybe a carotid aneurysm developing? Could that be putting pressure on the nerves locally? Anything that occupies space like tumours. I mentioned inflammation generally, now we're getting more specific, so we're looking at giant cell arteritis and temporal arteritis as very specific pathology that you might be have on your mind when you're thinking around this. Again, talking to patients about their diet, which we do increasingly when we're looking at the holistic health. So is there a nutrition, could there be a nutritional neuropathy? Have they been on a strict diet? Have they had a bariatric surgery? Is a consideration. Could they have small vessel disease, commonly linked to diabetes? So if diabetes is one of the comorbidities, have that as a consideration, especially if it's linked to atherosclerosis. Viral issues such as herpes simplex, herpes zoster, could that be a reason why there's been a neuropathy or a swelling of the nerve? Demyelinating disorders, classically MS is the one that we tend to refer to most commonly. Has there been another space occupying lesion like an abscess, and that's in the tonsils there we're thinking about? So have they had a sore throat? Have they got tonsil issues? Are there other anatomical anomalies or space occupying lesions that could be causing pressure on these nerves? All right. Classically, tumours, arteriovenous malformations and aneurysm are the types of things that we might have on our mind with regard to thinking about this. And then, of course, as I mentioned earlier on, COVID-19, it's a consideration. There's some discussion over whether it enters the body through the olfactory bulb or whether it actually causes impairment of the nerves. Certainly there is a consideration of the neurovascular component, this virus, which is affecting us all in so many different ways at the moment. So certainly an interesting time to get on top of your cranial nerve. Next time we'll look at some ways to test the cranial nerves, especially in this COVID-19 situation. So look out for the next of the Fireside CPD sessions, and we'll add to the knowledge base and keep the conversation going about how we can make our lives better in our small environments here, and that's the purpose of the Fireside session. So I hope you've enjoyed it, and look out for the next one. We'll be chasing around on Twitter in the usual way, so you've got an idea when the next one comes up. Thanks for listening, folks.